Domestic violence has received increasing attention over the past few years, attention that has framed the violence as essentially a form of aggressive masculine behavior. A growing volume of research contradicts this limited view of domestic violence. Domestic violence is now regarded as a phenomenon that can involve all members of the family, both the abuser and the victim. In order to successfully complete this course, be sure to read the accompanying course material. It contains additional information on this topic. We all know that victims of domestic violence do not come into a clinic or hospital and announce that they're suffering from domestic violence. Just as with drug or alcohol addiction, we have to diagnose domestic violence based on the symptoms that are presented to us. Recognizing domestic violence is like putting together a jigsaw puzzle. Medical staff should have a heightened awareness of a possible domestic violence situation when a patient is presented with the following symptoms. Somatic complaints without diagnosis, such as chronic pain, fatigue, headaches. Post-traumatic stress symptoms, gastrointestinal pain, unexplainable neurological changes, depression, multiple or erratic visits with a series of vague complaints. When patients confirm that they have been in a domestic violence situation, current needs should be assessed, as well as a request for a follow-up plan. Interventions in the primary care setting can improve outcomes in identified individuals. Regular follow-ups can help patients identify the potential impact of domestic violence on other health conditions. Keep in mind that domestic violence can be seen in all age groups, adolescents through seniors. Also, both genders need to be screened if risk factors or warning signs of domestic violence are present. Either male or female may be victim, perpetrator, or both. Domestic violence in either heterosexual or same-sex relationships. Therefore, providers should not assume that the perpetrator is of the opposite sex. The following is a list of common presenting symptoms that may represent the effects of domestic violence. Suspicious injuries may include burns or bruises in unusual locations. Central injuries, for example, the chest, abdomen, pelvis, perineum, facial injuries such as teeth, jaw, ruptured eardrum, human bites, and injuries from weapons. A related warning sign would be repeated visits for minor trauma. Symptoms may include somatic complaints without diagnosis, such as chronic pain. Example areas include abdomen, pelvis, back, fatigue, insomnia, or nightmares, unexplained neurologic changes, and headaches. Sexual problems, gynecological and or gastrointestinal conditions are a concern. These would include coercion in sexual relationships, irritable bowel syndrome, pelvic inflammatory disease, sexual dysfunction, sexually transmitted diseases, unexplained chronic gynecological problems such as vaginitis and pelvic pain. Another set of symptoms would be psychological problems. This would include post-traumatic stress symptoms like hyperanxiety or flashbacks, alcohol and or drug use, anxiety or panic attacks, depression, eating disorders, excessive use of or request for tranquilizers, sedatives, or narcotics, low self-esteem, and suicidal thoughts or attempts. Pregnancy-related problems should be looked at as well. This would involve abnormal bleeding, extreme worry about health of unborn child, inadequate maternal nutrition, late or inadequate prenatal care, past pregnancy complications such as spontaneous abortion, first or second trimester bleeding, poor weight gain, preterm labor, preterm birth, low infant birth weight, abruptio placentae, preterm labor, and teen pregnancy. Common behaviors of concern that may be connected with domestic violence would include angry or anxious body language, comments about emotional abuse or a friend who is abused, crying or sighing, defensiveness, fearful or poor eye contact, and a very flat affect, meaning little or no emotional expression. Changes in office visit patterns raise a red flag. Watch for appointments canceled by a partner. Change to use of emergency room or urgent after-hours care rather than office visits. Frequent changes of healthcare provider. Frequent late arrivals. Missed or late appointments. And sudden increase or decrease in frequency of visits. Another warning sign to watch for is angry, controlling, or coercive behavior of the partner. Make note if the partner attempts to minimize time the patient is alone with you or hovers, appears overly concerned, and won't leave patient unattended. Of great concern is when the partner does not allow the patient to obtain or take medication. Behavior of the patient to consider is reluctance to speak in front of or to disagree with the partner and fear of the partner, or defers to the partner to answer questions. Lifestyle changes that may be a risk factor would include the patient isolating themselves from family and/or friends. An additional factor would be if the partner has to be consulted with and attends social events the patient may have. Lastly, if the abuser seems to be at a lot of social functions without the abused partner and has excuses for their absence that seem unusual. Now let's join Dr. Michael A. Fraga. Dr. Fraga is a clinical director of the Ananda Institute in Santa Rosa, California. We recently discussed with him some of the misconceptions healthcare workers have about domestic abuse.
I think probably one of the largest misconceptions is that victims of domestic violence are primarily women. And again, this is promoted by and large of how we've come into the awareness of domestic violence to start with, which was the abuse of women and children, which is more readily reportable than men being abused by women for a lot of different reasons. One's the process of gender again. A woman slapping a man is more apt to dismiss it by saying, she just slapped me, it's no big deal. If a man slaps a woman, that can be anywhere from a misdemeanor to a felony charge, automatically for the same behavior going the other way. So we, in our own minds as men and women, see the same behavior different based on who's delivering it. So we've had it conceptualized for us with movies like The Burning Bed and so on, that domestic violence is this over-the-top, very crazy-making kind of behavior, and it generally involves some over-the-top crazy man abusing some undeserving women. That's very nice because it allows all the rest of us to marginalize ourselves out of it and go, well, that's not me, I don't do any of that. We don't have that going on in our household. And we miss a lot of the warning signs and of what constitutes those power and control relationships of inequity and imbalance. Domestic violence on some level has to do with minority populations, which it does not, and or that it's primarily centered in a certain level of our socioeconomic status, that lower income households see more family trauma and domestic violence. Lower income households may report more and may be more readily monitored by law enforcement, but the research clearly indicates that we have same or similar levels of domestic violence going on at the upper end. It's more sophisticated and we're less apt to report it because the consequences for picking up the phone are of greater significance financially, socially, personally, and because there is the financial wherewithal in those populations, we see the utilization of private therapists, private physicians, private programs. So it's kept large attorneys, if there are charges, things reduced to disturbing the peace or disorderly conduct, where it's not reflected in the criminal process that this is what's going on. So is it there? Yes. How it's treated is a differential response to how it's treated at the lower end, but again, it facilitates the misconception. And I think what's critically important when we look at all of this is that to remember that our whole idea of who domestic violence is and how it is, and even our data, is derived from the population that's arrested, not from the population as a whole. We talk about this silent witnesses. We talk about children in domestic violence or children in highly conflicted families. We have coined a term some years back called the silent witness, that children who are witness to, and then we also have children who are victims of. So if we stay with the witness side of domestic violence, oftentimes couples will say, well, we never fight in front of them, we send them to their room. That sounds nice on the surface. The bad news is those children are in their rooms listening. Oftentimes they're sitting at the top of the stairs or peeking around the doors. If they're not, they're doing their best to cover the noise of the yelling and the screaming and the banging by putting on earphones, turning on Walkman. So there's an immediate effect. The next obvious place is the tension between the couple that the children feel post the event, that things aren't like they are. When we look at those effects with children, we see acting out behaviors, anxiety, depression, sleep disturbances, sometimes decline in academic performance, that their grades start to drop. Attachment issues, which basically talks about being exposed to the parents over time as models of what it means to be, we'll take a male and female couple, a man, a woman, a father, a mother. That model, that set, influences the kind of people they'll be attracted to, not attracted to, and in the long term, the kind of, we talked before about parenting, the kind of parenting style they're going to affect, what constitutes love and what doesn't constitute love. Sitting with a 5-year-old on an evaluation one time for the court, and I asked him about his parents and whether they loved each other, and he said, oh yeah, they do. And I said, how do you know that your dad loves you? And he said, well, my dad hits my mom and he loves her and he hits me too.
Providing information about medical services and community resources in the clinical setting gives family members internal and external resources available for support, as well as increased awareness of the problem. This will involve some research and contact with local and state programs or agencies to obtain information and material. Most local programs are eager to help get victims to safety. Posters can be very helpful. They can be displayed in waiting areas with culturally diverse messages, indicating that the healthcare setting is a safe place in which to talk about domestic violence. Printed material should be available in waiting rooms, exam rooms, and restrooms. It is recommended that you establish strong ties and assure ongoing collaboration with local community-based domestic violence shelters and advocacy programs. Let's return to Dr. Fraga as we talk about these programs.
On the victim assistance side, places like the YWCA, they receive the VAWA, Violence Against Women Act, federal funds. And the YWCA primarily caters to women, I should make that very clear. There are very few resources, again, for male victims, and part of that has to do with the cultural resistance to acknowledging that a male can be a victim of domestic violence. The DA's office and the police department would be very preliminary steps, again, usually involving arrest or as part of an investigation for a potential one. There also would be no fee. They would more than likely point their finger to community-based organizations to help in that initial planning. At the point that we're doing a safety plan or an exit plan, generally we've got something going on. Several incidents, a history. We may or may not have the DA's office involved in it. We'd more than likely have a shelter or advocacy group involved in it, or somebody who's got some familiarity with the whole side of domestic violence and family trauma and the idea of restraining orders and shelters, and even what an exit plan constitutes and the need for it. A bulk of the shelters take single women with their children, and they take them for a variable amount of time. It depends on the situation and the circumstance. We also have victim assistance, which is a federal and state-funded piece, and the victims qualify for victim assistance funding, which would then avail them to psychotherapeutic services, medical services, and so on, so that they could seek those and have them compensated for out of this fund. But that's generally once they're housed somewhere. Cell phones for victims that can be donated to help them in emergent situations, short-term housing programs. Each county tends to have their own response system set up in compliance with the federal and state mandate in their area. It would be difficult with the both partners present to provide specific resources to somebody who's a potential victim. It involves a degree of staff training and professionalism, an array of resource material that would be in handout form to be able to avail somebody of that. And what we do with the ER staff and so on, we talk about a more general approach where we have injuries or we have the suspicion that that's going on, and so we talk about the family and we avail them of resources involving the YMCA that may provide childcare time for the mom and the kids if they need some cool out time so she can go shopping or this and that, and counseling at a local nonprofit for the couple as a whole to deal with financial stresses and relationship skills. And generally on that material, specifically with the YWCA and nonprofits like our own, we have a series of hotline numbers that are there as well and a list of services. Depending upon the severity of the relationship, providing something direct to somebody under the nose of the abuser is, we'll see it round filed before it gets out of the building, very possibly, but it will also increase the vigilance. It has a tendency to increase the vigilance of the abuser over the abused in the days and weeks after. We need to be very conscious about what we're doing with those folks in the minute and what can happen when they leave our offices or leave the clinic. We don't want to create a situation that's going to show up in a new incident post the contact.
Here's a review question to see how well you've retained what we've covered. It is recommended that you establish strong ties and assure ongoing collaboration with local community-based what? The correct answer is domestic violence shelters and advocacy programs. After making an assessment, medical personnel should decide on the type of referral to make based on the level of risk. A low-level assessment of risk could entail a referral to a local YWCA or YMCA. Be sure to check that they do offer advocacy services and counseling. If the level of risk was assessed to be high, the referral might be to a shelter, the domestic violence advocate in the DA's office, and or directly to the domestic violence officer of the local police department. Domestic violence advocates are trained professionals who can help patients develop a safety plan. In many communities, advocates are available through a domestic violence hotline or the local women's shelter. If a child is at risk, staff should refer to Children's Protective Services, which would set up a mandatory report if child abuse or neglect is evident. It is important that each clinical setting have a list of hotlines, agencies, and shelters available, so an effective referral can be made immediately if the patient is willing. The U.S. Department of Health and Human Services maintains a list of state domestic violence resources. This list can be found at womenshealth.gov/violence/state. You can also contact the National Domestic Violence Hotline for assistance in locating programs in your area. You can reach the NDVH at 800-799-SAFE. Let's return to Dr. Fraga as he talks about and examines escape plans.
At the point that we're considering an escape plan or an exit plan for an individual and their children, we're in a pretty dire circumstance. There's probably been some substantive physical abuse at the very least, and the escape or safety plan is at the point where there is an imminent risk to the safety, health, and well-being of the victim and or the children. And so it's time to go. Any interventive or preventive strategies that have been brought online have been ineffective and things are seemingly out of control. So really when we talk about an exit strategy, we're talking about something that's covert. We identify the resources that are available in the community, we identify support relationships, whether they're friends or family. We're involving the legal community in the form of restraining orders. Sometimes they're emergency protective orders or temporary restraining orders. so that when the individual exits the home, it's not uncommon to have the abuser served with a restraining order, and then that individual is placed in a shelter, a sanctuary. And shelters are confidential, so they're really a sanctuary. They're stashed away in the community or in another community, in homes or small complexes, where the abused and or the children can be housed for an indeterminate period of time safely while they receive some initial out-processing therapy for trauma and abuse, get their feet under them, and get the rest of the program together. Sometimes that means removing the children from the school for a brief period of time or transferring them to another school. Many states and counties like our county, when you file for those restraining orders, the addresses are sanitized, they're not on there, so when the abuser is served, he cannot determine or she cannot determine where the spouse is. So there's a lot of protective pieces that have been brought about to be put in place to do that. But identification of resources, looking at academics, addresses, support in family and around the community, and then the actual move. And it's not uncommon to see that happen while the other party is at work. They go to work one day and they come home and life has changed. For the better for the people who are being moved out, not necessarily the better for the abuser. And so that becomes one of the critical situations where we can see an elevated level of new violence or an aggression. That's why it's a very articulated plan that's, once it's executed, you roll the whole thing right out in a very short period of time. A good mantra for an escape plan, or an exit strategy as we call them, is plan your exit and exit your plan. Don't go across what you've planned. People sometimes, again, are caught within the negative dependency of the abusive relationship, and they just want to let the other know that they're okay or that the kids are okay. Unfortunately, in this day of caller ID and GPS tracking phones, there are a lot more things that one has to think about on the technical side of life. And sometimes that can be right down to not even letting their extended families know, because of loyalties or conflictual relationships, or just the extended family's appreciation or respect for what's going on that necessitates the need for an exit strategy to start with. Again, we go back to the idea that what goes on in our homes oftentimes only we know about and is not known to the full extent elsewhere. But oftentimes when an exit strategy is in place, and we're talking about children, the exit strategy is facilitated not by the victims concerned for themselves. It's facilitated by the victims concerned for their children. So immured are they within the negative aspect of the relationship that the primary motivation comes not for their own health and well-being, but for the health and well-being of the children. Lifestyle changes. Well, in the short run, they're going to be living in a shelter or sanctuary, more often than not with other women and children who have come from similar situations. So that's the good news and the bad news. They'll be surrounded by professional and pseudo-professional staff offering support, guidance, counseling, housing, finances, the care for the children and themselves. But it's a very significant dislocate. You come out of a life, you come out of a home, you're in a shelter, everything is up in the air. And so there's a very pronounced need to help the victim and the children see a future, that this is a temporary and transitional place. That can be complicated by whether or not we're using restraining orders or the need for a restraining order, which often is the case at that point. Whether or not the other half will forego the family home and move out, or whether the victim and the children have to find other dwelling, and all that is part of it. So the degree of change and transition can be quite significant. And we look for things like anxiety, sleep disturbance, depression, eating irregularities, weight gain, weight loss. I mean, those are just the psychological pieces that come about as a result of all of the real world changes that go on when you are basically taking a family apart for the safety of that family.
Here's another review question. If a child is at risk, staff should consider referring to what agency? A, Children's Protective Services. B, YWCA. C, the domestic violence officer of the local police department. Or D, WMCA? The correct answer is A. If a child is at risk, staff should consider referring to Children's Protective Services or an equivalent local agency.
I think it's important, and we see this a lot in court personnel as well, is to remember that the person's behavior, their verbalizations, their thought processes are very directly affected by the ongoing nature of abuse and trauma. So that oftentimes we can think, these people are crazy, all they want to do is go back, why are they protecting this person, why would you do that, why would you do that? And just to realize that that's the end result of degradation, humiliation, being micromanaged over time, where people begin to doubt themselves, feel insecure, even being away from the person who's abusive to them. We see that in children a lot, in highly conflicted families, where they will align themselves with the abuser as opposed to the abused, because it's safer standing over there than it is standing over here. And it's very conflictual for the child, but it's safer over there. At least I know that. I don't want to be over here on the receiving end, though that's an equal attachment. And for us who are not in it, oftentimes it makes no sense. It looks illogical. We tend to think people are weak. That's not the case at all. This is just where they are and where they arrive at after that chronic and frequent abuse.
Be vigilant in your fight to protect those who may have nowhere to turn. For Dr. Michael Fraga, I'm Frank A. Rincon. Thank you for watching.